Wow, a compliant audience. You saw the physical cue that somebody has walked up to the podium, so we are about to begin. My name is Lisa Simpson, and I'm delighted to welcome you to the Conversations about Cities and Health. And I get to turn it over to the leader of this effort, with whom we've been very happy to partner, Sandro Galea. Sandro?
Thank you, Dr. Simpson. So first of all, welcome everybody. Thank you all for coming here, and thank you to a number of partners behind this. This is organized by our Boston University School of Public Health, the Initiative on Cities at Boston University, ACADEMYHEALTH, which Dr. Simpson is CEO of, and the BEAUMONT Foundation, which Dr. Castrucci, I don't know if he's here yet, is the CEO of. The genesis of this gathering really is a confluence of a number of conversations that have been happening between those of us at Boston University and ACADEMYHEALTH over the past couple of years around this notion of cities and how cities influence health. And you're all here today on this lovely day outside, so presumably it's because you all get the fundamentals of why we're here. But the bottom line is that more than half the world's population now lives in cities, and more than 80% of Americans live in cities. And insofar as health is generated by the world around us, cities are a human-made part of the world, which gives us a tremendous opportunity to actually create cities that generate health. And there's been a fair bit of scholarship that has been going on about this over the years, and one gets a sense that that scholarship has been accelerating in the past decade, and as I think urbanization has been accelerating worldwide, which makes a lot of sense. From our end, we've just published a book called Urban Health. As you're going to be hearing today, the Initiative on Cities has a new health survey as part of the Menino Survey of Mayors, and many of the other speakers live urban health, live cities and how cities influence health in their day-to-day life, as you're going to hear. So really, we wanted to bring people together here in DC, capitalizing also on a confluence with ACADEMYHEALTH that's just finishing their annual meeting, to do a small convening that says, can we bring ourselves up to speed about where our thinking is at, about how cities influence health, as a way of nudging our ideas forward. That's really the intention behind today. I'm delighted that Dr. Simpson agreed to moderate this, and I'm really going to turn it over to her and to the speakers. Thank you all for coming.
Thank you, Dr. Galea. So the format for today is I'm going to invite all the speakers up and introduce them by, as you see, sort of name and title. One speaker, Monica Valdez-Lupi, was not able to join us in the end. She sends her regrets. And then they're each going to speak for about 10 minutes, and as they take the microphone or speak, they will also, in their own voice, tell you a little bit more about themselves, so you understand the perspective and sort of experience they bring to the question of cities and health. So I was delighted when Sandro reached out to us at ACADEMYHEALTH. We are the National Association for Health Services Research and Policy, and that's the evidence base we need to inform policy and practice. And this conversation about cities and health, and particularly with our first speaker talking about the survey of mayors and their priorities, is really critical because we want the evidence, the research to be informed by the needs of those who try to change health and healthcare. And so having that kind of stakeholder input is critical as we then drive our evidence to address the real needs of communities and populations. So it was a great opportunity, and I really want to thank Dr. Galea and the BU School of Public Health for organizing this and inviting us. So with that, let me invite all of the speakers up here to come and sit, and then we will be somewhat informal. And the tall people just walk right up. They don't need steps like me. And so I will again introduce all of them, and then we will begin. Our first speaker will be Dr. Catherine Lusk, who is the executive director of the Boston University Initiative on Cities. Julie Marita, I'm actually going to dispense with honorifics. Julie Marita, the commissioner of the City of Chicago Department of Public Health. LaQuandra Nesbitt, who is the director of the District of Columbia Department of Health. Sarah Rosen-Wartel will be our final speaker in the initial part. But what's important about this session is not just what we share of our perspectives and contributions, but the dialogue that we'll have amongst us, first amongst ourselves on the panel, and then importantly with all of you in the audience. I also want to call out to folks before I turn it over Catherine that I hope you picked up a copy of her just released new report from which she will speak on mayors and the health of cities. And with that, Catherine, will you kick us off?
Now, I can't see, so bear with me. Oh, there it is, okay. It's a pleasure to be with you all today. As Lisa said, I'm Catherine Lusk from the Boston University Initiative on Cities. For those who haven't heard of us before, I will tell you up front, we are biased. And if anything, we are biased in favor of cities, and we are particularly biased in favor of mayors and mayoral leadership and the role that mayors play in producing vibrant, healthy places. So it's a pleasure to be sharing with you the results of our recently released report, Mayors and the Health of Cities. Special thanks, of course, up front to our, not only our funders, Citi and the Rockefeller Foundation, but folks who really have been partners throughout this process. I like to characterize the findings of this report as telling us what mayors talk about when they talk about health. So the first thing we did, let's see. Nope. You guys want to click forward? Can someone in the back click? Oh, there we go. If you want to just click through, if this isn't working, feel free. Okay. So a very quick word on methodology, so you know who you're hearing from and who you're hearing about. The findings here are part of an annual project that we conduct based on live interviews with a representative sample of mayors across the country. This year we did interviews with 110 US mayors from cities with population over 75,000. So importantly, it's worth noting this is a study of perceptions and attitudes. And what we wanted to do was ground those perceptions and attitudes in ground truth, in prevalence of health-related statistics. So click on. So we combine mayors' attitudes with municipal level statistics from the City Health Dashboard. Thank you to the NYU Langone group for putting this work together and saving us a huge amount of time. And in addition, please click on, we combine it with supplemental information where there were gaps in some of their data. So first things first, what did we find? Click forward. Thank you. We asked mayors, what is the greatest health challenge facing your community? So this word cloud illustrates what they told us. First things first, obesity and related chronic diseases like diabetes, hypertension, and heart disease were the most frequently cited health challenge confronting their community, followed closely by opioids and addiction. 14% of mayors cited access to care, whether that was cost of care, underinsured or uninsured residents, or challenges getting access to a healthcare facility. Click forward. We also heard 15% of mayors reference mental health. Only 8% cited mental health as the leading health challenge in their community, but 15% talked about it in some context. So they may have mentioned addiction, they may have mentioned homelessness, and then included references to mental health challenges in concert with that. 27%, so only about a quarter of our samples, cited specific groups, including children, both infants and health, as well as the homeless, as the populations of greatest concern in their community. Click forward. We were struck, and we've been doing these interviews for 5 years on a range of topics, and we always find that mayors talk with great insight and care about a wide range of topics, but there are also sometimes issues about which they know relatively little. Surprising to say that we do actually find that. Thank you very much. We actually were struck by the fact that mayors in their interviews with us are using the language of public health, language that's very familiar to all of you. A big city mayor actually, when asked about the greatest health challenges in his community, said simply, poverty. Another one talked about the trauma associated with violence and adverse childhood experiences impacting social determinants of health. Another referenced sedentary lifestyles, directly and indirectly contributing to chronic health problems, including the leading cause of mortality in the US. And others said, you can look at the issues people are dealing with, diabetes, cancer, STDs, but at the core is access to health care. Oh, I don't have to say click forward, I can do it. Okay. We also wanted to understand who was citing particular challenges. What was the prevalence of some of these issues on the ground in their cities? So bear with me while I explain what you're looking at. What you see here are 31 cities that elevated obesity and related chronic diseases as the leading health challenge in their community. So each city, each column represents an individual city. So all the way on the left, you see a city that's remarkably healthy, right? All green dots. That means they're in the bottom tercile for rates of obesity, rates of diabetes, number of cardiovascular disease deaths, high levels of physical activity, low rates of inactivity. All the way on, all the way on your right, you see cities that are red, meaning they are in the top tercile. So they have the highest rates of obesity, the highest rates of diabetes, the highest rates of cardiovascular disease deaths. So what we see is a remarkable degree of heterogeneity of the cities that are elevating a common health challenge. So we have relatively healthy cities across a range of dimensions and relatively unhealthy cities across a range of dimensions identifying a common problem. And we have the same analysis in the report. I'm not going to go through all of it, but I wanted to share with you this because it gives us insight into the fact that we always presume that statistics are what drive mayoral priorities. But in this case, it may actually be attitudes. So one more data point, which is we actually looked at the cities in our sample that had the highest rates of obesity. And only about a third of those cities in the highest tercile actually cited obesity as the greatest health challenge. We also asked mayors, tell us about how accountable your constituents hold you for the following health challenges. And we asked the question this way because we know that mayors, a relatively small number of mayors, actually have responsibility for a municipal health agency. And we didn't want to let them sort of dismiss the question. So we wanted to pose to them, what are the issues that your constituents sort of put at your doorstep and the things that they look to you to resolve? And we got a different set of answers. Now, fair enough, this was a closed-ended question, but we were still really surprised by the results. So you'll see here, at the top, the issues that mayors believe they're most accountable for are traffic accidents, gun violence, and lead and other toxicants. And at the bottom is a list that we heard previously in relation to the leading challenges in the community. So they believe they're held least accountable. Of all these issues, they believe they're held least accountable for obesity and issues like mental health. We really wanted to understand why, what might be driving some of these differences in their opinions. One possibility, of course, is that most cities and most mayors have access to the resources of transportation departments, police departments, inspectional services, and housing departments. So it may be that they're presuming, well, constituents are looking to me to solve that problem because, of course, I have the resources at the disposal to tackle those problems. It may also be that issues like obesity, they may associate with individual risk factors or individual choices in areas where they feel they can have less influence. One thing we were able to validate was whether we heard a different set of responses from the mayors, the minority of mayors that actually have a municipal health agency. So we found in our sample and across the country, only about 20% of cities actually have a local health agency that has the resources to help them tackle challenges. The remainder have obviously a county or a regional entity that's tackling and responsible for tackling public health. But actually in our analysis, we found that health agency type was not correlated with perceptions of accountability. So we got the same sets of responses whether or not a mayor actually had access to a health authority. Something else we found actually did help to explain perceptions of accountability. We found significant differences by party affiliation in gender in some health challenges. So at the top, you'll see Democratic mayors feel that their constituents hold them far more accountable for gun violence in their community relative to Republican mayors. Interestingly, they also feel more accountable for hunger and malnourishment relative to their Republican peers. We also see a distinction between women mayors and male mayors. So women mayors, 60% of them believe that they're held accountable for hunger and malnourishment, and 45% believe that they're held accountable for mental health. And that's 18 or 19 percentage points higher than male mayors. Prevalence mattered only once. So we were really interested in understanding, does the prevalence of an issue, whether it has in fact reached sort of crisis mode in a community, impact mayors' perceptions of accountability? The only instance where we saw it was with regard to opioid overdose deaths. So for those cities that experienced higher numbers of opioid overdose deaths, mayors believe that their constituents are looking to them to tackle the problem. In summary, many mayors talk knowledgeably about health, including social determinants. They report obesity, addiction, and access to care as the key health challenges facing their community. But interestingly, it's a heterogeneous group of cities that are identifying common challenges, which for the public health community may mean that you find allies in unexpected places. Perceived accountability differs. Traffic accidents, gun violence, and lead and other toxicants actually top the list of issues for which mayors believe voters are holding them responsible and looking to them for solutions, whereas obesity is actually the lowest, perceived as sort of the least accountable. Accountability may actually be attributed to resources, although it's not attributable to dedicated health resources at the local level. And lastly, some significant perceptions actually differ based on mayoral political affiliation as well as mayoral gender. Thank you to my co-authors. For those who want to see more, the full report is available at surveyofmayors.com, and there are also hard copies out in front for you. And I look forward to the rest of the conversation.
Thank you. Thank you so much, Catherine. That was wonderful data. We're now turning to Julie. We have two city representatives who are directly going to talk about what's going on at the local level. Again, this is about local cities. So, Julie.
Good afternoon, everyone. I'm Julie Marina, Commissioner for the Chicago Department of Public Health. Just as a little bit of background, I'm in transition right now. So I've been at the Department of Public Health for 20 years, about 4.5 years as the Commissioner for the Health Department. But on the 24th of this month, I'll actually be moving to the Robert Wood Johnson Foundation. So I am in personal transition, but then the city of Chicago is also in transition with our new mayor. So I'm really curious. It'd be really interesting to see how Mayor Emanuel had responded to this survey in the past and see what Mayor Lightfoot had and see how she would respond. I have a sense their answers will be very, very different. But it's very, I love hearing the results shared. I love looking through your report. It was so relevant and to the way we've been working and operating in the city of Chicago. What I'll do is talk a little bit about Healthy Chicago 2.0, which is, and the work that the Department of Public Health has been doing over the past 4.5 years. Just to give you context, the city of Chicago is made up of 2.7 million people. The racial and ethnic breakdown is about a third African American, about a third Hispanic, and about a third white. So that's the environment that I'm working in and the population that I'm serving for the past 20 years. Am I doing something wrong? Maybe I'm, aha, that's what I was doing. Yes. So it's interesting, having heard what, how mayors describe what they're being held accountable for and yet what they prioritize, and how some don't actually have health departments. It's very interesting. I think in the past, public health departments and public health entities played a major role in delivery of healthcare services, but with the advent of federally qualified health centers, Affordable Care Act expansion, the role the public health departments is playing is much less of this delivery of healthcare services, much more of a policy, systems, and environmental change type of approach as we address public health issues. And I don't know that mayors have that understanding yet. I believe that many mayors actually have a perception of their responsibility in terms of dealing with and addressing delivery of healthcare services on a very limited scale, because when you think about, no matter, even when health systems are public health is providing healthcare services, it's really on a small scale compared to the private sector and to federally funded entities that are providing those services as well. So it's just really interesting to hear about that difference in opinion. What I'll talk about is how we are actually using our public health approaches to address root causes of health in the city of Chicago. And that's been a transition that we've focused on just really since 2016. Just to begin with, I wanted to just talk about the success that we've had because we've used policy systems and environmental changes over the past decades. We look at teen birth rates as examples of how progress has been made in the city of Chicago. So we can see that teen births have gone down, and a lot of that has to do with policies like Affordable Care Act that made long-acting reversible contraception readily available. We also have we've seen dramatic reductions in elevated blood lead levels among children. So you can see that the policies in terms of removal of lead from gasoline and from lead paint, that we've seen these dramatic improvements in lead levels. In addition to that, things like like newly diagnosed HIV cases in the city of Chicago have dropped to the point where we're now talking about getting to 0 by 2030. And that, again, is because of programs like the Ryan White program, HIV prevention programs that were heavily funded to really address some of the social determinants of health among people living with HIV, as well as the healthcare delivery of services. So you can see the dramatic improvements that have been made by public health. And then again, as a result of the Affordable Care Act, you can see how the percentage of uninsured in the city of Chicago has really dropped dramatically. So you can see we've gone from 1 in 5 to actually less than 10% being uninsured. So dramatic improvements in health overall, using policies, systems, and environmental change. However, we're not really satisfied with what we were seeing in the city of Chicago, despite those progress that had been made. What was concerning to us is when we looked at our data more carefully, you could actually see that there are significant health disparities that persist. And so this is it's a central part of the city of Chicago. So the lines that you see represent our transit lines, so the red line, the green line, and the orange line. And in the central loop area where I work, the life expectancy is 85 years. If you take a train ride due west on the green line, the life expectancy in that community is 72 years. So dramatic differences. And you can, again, see the differences when you look at the south side at 69 years on the red line south. So dramatic differences. So though we've seen those dramatic improvements in health overall over time, we're still seeing these persistent health disparities. And that was really disturbing for as long as I've been working in public health, we really have used an equity type of lens to assure the limited resources that we have are really going to those communities or those populations that have the greatest need. But this persistence of this type of problem with overall improvements really was very disturbing to us. So as we thought about how we could address these persistent disparities, we started thinking about the problem with just what we focused on in the nation really has been on treatment versus looking at the root causes and prevention of poor health. And so despite the fact that we spend more than any other developed country in the world on treatment, our health outcomes are much worse. And so you really, in order to address these health disparities, particularly like things like life expectancy, we have to address these root causes. And so looking at the social factors and economic factors and physical environments in cities, in urban areas, in rural areas as well, this is how we felt we really needed to improve the length and the quality of life, is really by addressing the root causes of health and not focus so much on treatment overall. So in 2016, we launched our Healthy Chicago 2.0, and that health plan prioritizes health equity, and we led with health equity at the time. It didn't take us long to realize that we really couldn't talk about health equity without confronting race equity. And so over time, we've really started confronting that issue more head-on, and you'll see that as we talk about our next plan, we really are calling out race equity much more strongly. But in order for us to achieve health equity, we really felt like the key tenets of our plan were really focusing on leveraging data, prioritizing the root causes, and then emphasizing collaboration. Because we don't own the root causes of health. When you look at housing, economic development, transportation, public health does not own those things. And so in order for us to really make a difference and address those issues to improve overall health, we really have to focus on these collaborations. And so those core tenets are what have led our work in the past few years. And I'll talk about some of the initiatives that we've had over the past couple of years that I think have been very helpful and have been moving us in the right direction. So in terms of leveraging data, and one of the key things that we felt is that public health has always had access to a plethora of data. We have access to all kinds of data, but how much we use the data and share the data is somewhat variable. And it's really, really important for us, since we have these data, to make these data accessible. And so when we think about increasing power in communities, I was talking to Dan Jernigan about the different things that we can focus on to improve health overall, is communities having to have power, and information and data really give them power. So we took all the data that we used to help us create our Healthy Chicago 2.0 plan and made it available to the public through our Chicago Health Atlas. So there's over 150 indicators, and the number of indicators keep growing because we get other sources of data that we've been adding in, and make it available to anybody who wants it. So academics are using it in the city of Chicago. Community organizations are using it to apply for grant funding to demonstrate, because the data are looked at by population, racial and ethnic groups, by different demographic characteristics, but also by geography. So the city of Chicago has 77 community areas, and the data are available per community area. And so these communities can then advocate for resources using these data. My daughter just graduated from college, and she took a data science class at the end of her last semester, and she needed to work on a project with an open data set. And so I referred her to this data set. And she had so much fun playing around with the teen pregnancy and gonorrhea rates correlations by geography. But I think she took it back to her class, and the class was really excited about having these data accessible. So I think there's so many ways that these data are useful and need to be made accessible. So this was a great example of how we're leveraging the data, not only to inform our work specifically, but also to make it accessible to others to take advantage of it as well. Oops. So that's just an example of how we leverage data. There's other examples as well, but in terms of how we're prioritizing root causes, because we really felt like we put a stake in the ground and said we need to focus on root causes of health, so housing, transportation, economic development. We partnered with our housing authority, our human services agency, some healthcare systems in the city of Chicago, and we created a flexible housing pool modeled after the LA County flexible housing pool, which created a pool of funding that can be used for permanent supportive housing for people who don't meet HUD criteria for housing. And so we have created a similar pool. We had $1.7 million that the city of Chicago put into it. Cook County Health System just provided an additional $1 million. Blue Cross Blue Shield is contributing as well. Our goal is really to have a variety of sources in contributing to this pool. And the focus of the pool is to really address permanent supportive housing for people that have substance use disorder, serious mental illness, and also those who are justice involved who would not qualify for a HUD funding ordinarily. And so this is an example of how public health, we brought our data, we highlighted the need and the impact that permanent supportive housing can do for individuals with serious mental illness, substance use disorder, and justice involved individuals, and the impact that has on healthcare utilization, healthcare costs, and health outcome overall. So an example of how we've been focusing on housing, but in partnership with key city agencies as well as community organizations. Another example of a good initiative that we've done in the past few years, which is really exciting, is working on this community development initiative. Because we put our stake in the ground in public health and said that we want to look at root causes, other partners reached out to us. So the Metropolitan Planning Council, urban planning group in our city of Chicago, and then also some community development organizations, community development financing groups reached out to us and said, we want to work with you on this bank redevelopment. The Cook County Land Bank purchased this deserted bank and then asked us to work with them to help inform the RFP that they were putting out, so that the developers that were competing to take over this building had to contemplate various factors, and we were able to insert some health factors, so air quality, walkability, access to food, mental and emotional well-being in the development itself, to really influence the type of development that happens in this community. So it was really looking at this as we do these kinds of things to begin with on a small scale, but then build this into other development within the city of Chicago. And suddenly health factors are being contemplated as we're developing some of our underserved communities. And again, I didn't say this to begin with, but this is one of those communities that is south of the central business district where the life expectancy is quite low. So this is the kind of work that we're really excited to be a part of in terms of helping to improve the conditions within the city, so that we're not only improving chronic diseases like obesity and diabetes, but we're also addressing violence and mental health and substance use disorders as well. So that's a great example of a partnership that we had with our external partners. We also felt it was really critical for us to partner within city government, because we all work in our little silos and we do our work as we're told to do, either by our funders or by law, but we don't necessarily collaborate very well together. But early on, after launching our plan, we created a health and all policies resolution, which required our city agencies, all of them, to work with us and to come up with recommendations for how they could incorporate health into their policies, their plans, the work that they're doing, so that we can actually make sure that we're moving along the same direction. It was a fun initiative. I got to know all the other commissioners very well. We came up with 16 different recommendations, and there's been some great work that's happened as a result of the resolution. The Vision Zero is one example. It's a national initiative to actually eliminate all traffic fatalities. But it was an example of how the Department of Public Health worked with Department of Transportation, our police department, to look at public health data, traffic crash data, come up with educational campaigns, re-engineering of really high incident and dangerous corridors to really make them better overall. So it was an example of collaboration. The Good Food Purchasing Program is another great example of where we actually established a policy for all city agencies to strive to achieve good food purchasing criteria or standards. So it's the quality of food, local purchasing, how the food producers are treating their employees, how they're treating their animals. It's all those factors. We have $200 million worth of purchases on an annual basis that the city of Chicago makes. If we channel that all into good food purchasing, we make a big difference overall. So it's exciting to see how our reaching out to our partners help them to think of us when they were working on different initiatives and then make sure that we're contemplating health as these kinds of policies or these programs are actually being rolled out. Oops. And then this is the last example that I'll share with you all, but it's called Westside United, and this is a collaboration of 6 different healthcare systems in the city of Chicago, and they're all in the west side of Chicago. So when I pointed out that green line that went out and how the life expectancy was so much lower, these health systems all serve those communities in that area. And what they've done is they've come together to work together to address the determinants of health, to really look at that west side and develop it from an educational perspective, from an economic vitality perspective, because they see what the power that they have as a combined group. You know, they have over 6,000 annual hires, over almost $3 billion in supply and service expenses, over 40,000 employees. If they start thinking about what they do with all that and how that impacts the communities that they serve, they can make a really big difference. And so they've outlined their priorities as looking, oh gosh, now I'm not going to be able to read these because it's too far away. But part of it is provision of access to healthcare services, so whether it's physical health or behavioral health, but then there's also access to food, healthy foods, and then there's education, addressing educational disparities in those communities, and then lastly, the economic vitality. So I was with this group talking about the types of initiatives that they're taking on, and what was very interesting to me is that they were willing to talk about purchasing and using local businesses within those West Side communities at a higher cost than bigger businesses where they could get a lower cost, because at some point they felt like that even though they had to pay a little bit more, the benefit to the community would overall benefit the community itself, as well as health outcomes and health utilization healthcare utilization within those communities themselves. So they're seeing the benefit of these kinds of economic community development investments and the impact that they as anchor institutions in those communities can actually play. And so the creator of this Westside United credits the Department of Public Health for really kind of inciting and catalyzing their work, because we said, public health is committed to working in this direction. We have these data, we'll share these data, we want to bring partners together. And so they credit us for this work, but what they've done with it has been just truly phenomenal. And we are partners on this initiative, but they have really taken it and run with it. And so it's been really, really exciting to see that this kind of initiative is happening. What we're wanting right now is really to have this same kind of Southside United initiative happen on the south side of Chicago, because that desperately needs it as well. That hasn't happened yet, but I'm confident that something will happen in the near future. And then just in terms of what's next, the Department of Public Health our 2016 plan was launched. It was a 5-year plan. It was meant to end in 2020. With the mayoral transition that we had, we really felt because of the great work and the excitement and the momentum that we've had related to Healthy Chicago 2.0, we didn't want to lose that. And so we're in the process of finalizing our Healthy Chicago 2025, which will be announced in the Mayor Lightfoot's first 100 days. So this can carry forward this approach of looking at equity and really focusing on race equity, not just health equity, but specifically in calling out the need to address race equity, addressing root causes of health in collaboration with partners, but highlighting those health outcomes and those health issues that the progress has not been made as we'd like it to have been. So it's so interesting to see the mayor's survey, because obesity is among our top priorities, as is opioids, infant mortality, and actually maternal mortality as well, because of the significant disparities that we have in Chicago. And violence is an ongoing issue. And we're also looking at environmental justice in particular, because we feel like this is really a critical area too that makes such a big difference in terms of health outcomes in our communities. So those are the challenges that we're looking looking at facing, but I believe that our belief, strong belief, is that the approach that we're taking, looking at things through a health equity lens, using policies, systems, environmental changes as a framework for our work, and then really addressing the root causes. We'll address all those things when we address the root causes in this place-based type of an approach. So we're optimistic that we'll make a difference. I'll stop there.
Wonderful. Thank you, Julie, so much. That's wonderful to hear from Chicago. So now we get to hear from our backyard. LaQuandra Nesbitt is going to tell us about the initiatives here in the district.
So I'll have a disclosure. You know, you come to do presentations, you say, I won't need my glasses. And then now I'm like, oh, probably should have put on my glasses. So please do bear with me. I didn't realize the distance here. Still think I'm a young health director. So in part of sharing who I am, at one point of time, I was a young health director running a public health agency in Louisville, Kentucky, which I did for 3.5 years. And now I've been here leading the Department of Health here in the nation's capital for the past 4.5 years. And I similarly have a bias toward to large public health agencies and cities, but interestingly, we find ourselves in the nation's capital sometimes functioning as a county and a state health department. And so there's lots of similarities between what Julie and I do, and we find ourselves being collaborators. We've actually written an editorial about the role of cities in improving health, and big cities in particular, and the role that we play, and it's been an evolving role. But there's also some things that we have in common, and so I'll spare you that. All of the trends that have happened in Chicago have also happened in DC in terms of seeing improvements in overall health for our population over the past decade. But then we also have some of the things that did not improve. So still having a gap in life expectancy from residents here in Washington, D.C. area, where we tend to divide ourselves up in quadrants, where residents in the southeast quadrant of the city have a 21-year less life expectancy at the time of birth than residents in the northwest quadrant of the District of Columbia. And so when we're trying to communicate to people where we need to still make improvements, eliminating that gap in life expectancy still remains a priority for us. We tend to do some things as well in terms of being able to establish what our priorities are. When I came to the district 4.5 years ago, even in confirmation hearings, I was very adamant about not naming a specific health issue as the priority for the District of Columbia, and being able to focus on infrastructure types of ways that we wanted to focus and have strategic priorities, and focusing on a culture of health and wellness and getting people to get out of this very disease-specific way of thinking, thinking about ways that we wanted to focus on addressing the social determinants of health in the district, recognizing that the government alone doesn't improve the health of its population, so strengthening the public and private partnerships in the district, closing the chasm that exists between public health or population health, but public health and clinical medicine, recognizing that there are assets in both of those domains that cause us to have to improve the health of the population. There are things that we recognize in public health first that we need to communicate to those who are in clinical medicine, and there are things that clinical medicine recognizes first that need to be shared with public health in order for us to work collaboratively together to improve the health of the population. And then implementing data-driven and outcomes-oriented approaches to program and policy development. For a very long time, we were a needs-based organization, or governmental public health was very needs-driven. The community has a need, and we fill that need, and then we walk away. We never go back to see if the outcomes that we thought should be achieved as a result of meeting that need were ever realized. And so we want to be more outcomes focused than just simply meeting needs of the population. In the District of Columbia, like many cities, we've seen tremendous growth in our population. Just simply from the first time that I was in the district, from 2008 to 2011, I would talk about our population was 591,000 people. Today, we talk about our population being over 700,000 people. Interestingly, and it's just a fun fact, the 700,000th resident, how we decided this was baby 700,000, but Cooper, his mom, actually worked for the health department. And we did not rig that. The mayor's office was like tracking for baby 700,000 in Cooper. His mom actually worked for DC Health. So we've had that amount of growth, right? 591,000 people. But the growth that we are experiencing when we actually look at it in terms of what that means in a growing urban area, when you look at your housing needs, when you look at the demographics of the population, it's not what people have typically thought about as Washington, D.C., Chocolate City, a majority African-American community. We're seeing our larger growth be in whites. We're seeing less growth in African-Americans. We're also seeing most of the growth be in the polar opposites of the income spectrum. So growth is happening at the individuals who are lower income or who earn over $100,000, $150,000 a year. So our middle income population is shrinking. We're losing them to the suburbs of Maryland and Virginia. So these types of things matter when we're trying to think about what that means for the health of our population, but also for our overall planning, economic development, and what our tax base is going to look like, and when we're talking about achieving equity, right? So making sure that when we talk about it in terms of inclusive prosperity in the District of Columbia, making sure that everyone has an opportunity to share in that. Just quickly, because we have to orient ourselves, we're always thinking about, well, what happens to people in the District of Columbia? It's the same thing that happens to people everywhere else, right? Heart disease, cancer, et cetera. But then we have some things that happen in some populations don't happen in others, right? So when we look at what happens to whites, the 10 leading causes of death, there's 0 when we look at homicides, right? But then in our communities of color, blacks, Hispanics, we have rates of homicide in the top 10. So when we're doing our planning, it's important for us to not look at the total population, but also to look at our racial and ethnic populations, which are a vast majority of the residents in the District of Columbia. Now, because I'm thinking about this in terms of how do we plan, how do we even identify the priorities, how do we even come about to address health of the population as a city, we have all these inclusive planning processes. It's one of the beauties of being a city instead of being a state, whether you're a large city that has 2.7 million people. Interestingly, DC is considered a large city, even though we only have 700,000 people. But when we go to our city meetings, there are some cities that have 10,000 people. And we're like, wow, I could easily take care of them. That's a neighborhood, right? So, but when we're talking about cities and how some of the cities and counties are designed and planning for their population, there's a number of inclusive processes that we have, and these processes tend to be ongoing in terms of being able to mobilize groups, be very inclusive in the process. And while we may depict them in the way that makes it seem like each one of these are a very separate state, you're always in some part of this process, and it's intended to feed back to one another. And we do this in partnership with many of our community members. It's, again, one of the ways that we create our outcomes-oriented, data-driven processes. And it's one of the ways that we try to have some modicum of control, right, of what we're doing, what we're designing, what our community health needs are, what our plans are over either a 3-year period, a 5-year period, or a 10-year period. And we produce plans. So we have the very large DC Healthy People 2020 plan, has over 150 health indicators in it, spread out over 20 focus areas, 13 of them that may be more priority than others. And then you have other smaller plans, not all of them listed here, but 90-90-90-50, which is our strategy for addressing the HIV epidemic in the District of Columbia, and a whole host of other plans around perinatal health, et cetera. And then we strengthen our public-private partnerships by creating websites like ourhealthydc.org, which is similar to the Atlas that they have in Chicago, where people can access this data, where they can track progress on our Healthy People indicators, but they can also partner with other community-based organizations or partner organizations in the district who are doing similar work. And it's an opportunity for them to network virtually. So we convene people in person. We have over 80 formal and informal boards, commissions, advisory committees, et cetera, that help us facilitate our work. Some of them are mayorally appointed. Some of them I appoint the members. Some of them are convened through some of our funding requirements, but there's a number of ways that we convene people to advance the mission of our organization or to advance the goals that are set out in a number of our health plans. So there's a lot of strategy put into improving the health of a community in a city where we have advantage of being able to quickly mobilize, being very flexible, and being able to get input from the citizens that we are impacting, right? So a lot of civic engagement that is put into this process. And again, planning very strategically for three-year, 5-year, 10-year increments, and having sort of a continuous quality improvement perspective in mind. And then things like this happen, right? So you've got your agenda, you've got your plan, and then something happens as a health leader where I have to maybe take an action that then takes control of the narrative. So you can imagine that in a place like the District of Columbia, I'm paying attention to maternal and infant health on a regular basis. I'm passionate about it. I left Washington, D.C. and was appointed by a governor to inform maternal and infant health in a completely different state. So you can imagine I care about this very deeply. So when something like closing an obstetrics unit in the only hospital or healthcare facility in a quadrant of town where most of the residents are lower income, have fewer access to inpatient healthcare facilities than the average resident in the city, this captures the narrative around what the focus for health for the city should be, and it captures it for a very long time. And people forget or never knew that there's an entire comprehensive strategy to addressing perinatal health for the residents of the District of Columbia, and that this comprehensive strategy has been in place for a couple of years before the one place that people deliver a baby, which is only one part of birth outcomes or perinatal health outcomes. And it tends to take away from the way that a city addresses the overall health for its population. So one of the challenges that a health director, a health commissioner, a health leader, and even those who are doing the groundwork on a day-to-day basis separate from the government has is being able to remain focused on the other 90%, 95% of the factors that contributes to the health of the population when a single incident captures the narrative. And being able to focus on these 6 other domains that are related to improving the health of a population. And so we have to be able to be responsive to that in cities, even though, interestingly, as the report shows, is that politicians or the mayors, the elected officials, don't always feel responsible for the access, but there often is a cry from the public to do something about restoring their access, do something about creating equity in access across their jurisdiction, and then you have to be responsive to that as a health official. And how you communicate your care and concern for that issue when you're seen as the person who took it away is critically important. And one way that you can do that is you can partner with the elected official to put that platform on a totally different plane. So we had this perinatal health framework that was around. There were many of the key stakeholders who were helping to implement it. The work was being done, but not as many people knew about it as possibly could. So the mayor got behind it, gave backing to it. We hosted a summit last year in the fall, and over 1,000 people attended. And it really gave the public the opportunity to get a deeper understanding of what are the things that we do have in our community other than this hospital or the resources in this hospital that are no longer present that help to improve the health of the population. And we're gonna have a focused conversation about that in this room with over 1,000 people attending, with experts both locally and nationally facilitating a discussion about what it takes to make our population healthy. And the things that came out of that summit were, we need to improve the quality and access to clinical care. But then other things that came out of that conversation was, we need to address implicit bias and cultural barriers to care, right? So even if we have access to care, access to quality clinical care, which I'm imagining everybody in this room knows that it's not just about access to health care. We pass out insurance cards in the District of Columbia. Only 2% of our population is not insured. 40% of the people that we insure are publicly insured, which means they pay little to nothing for the health care that they receive. But if there's implicit bias in that care, there are cultural barriers to the care is not deemed culturally appropriate, not just culturally competent, but culturally appropriate, people won't take advantage of its availability. And then the other thing that came out of there was implementing strategies to increase community engagement and address social determinants of health. These were themes that came out of that summit that were very specific to maternal and infant health, but they are themes that we all know are related to more broadly addressing the social determinants of health in DC. So we established in DC Health, what the name for our Department of Health here in DC, an Office of Health Equity in 2015 when I returned to the department. And we have been socializing the construct of social determinants of health as it relates to specific factors that influence health, and working very closely with our other agency partners who we know that the policies that they pass or that they implement, either from organizational policy perspective or the legislative policies that they support, can either facilitate good health in our community or can cause adverse impacts to the health of our community. And as a result of that, we have identified 9 key drivers for health and that can promote health equity in the District of Columbia. We have published those 9 key drivers in the Health Equity Report, and we show how all of those key drivers and different aspects of those key drivers are correlated with life expectancy in the district across 51 different neighborhoods. And because of that report, we have been able to do things, and this didn't just happen overnight. There have been some things that have been implemented over time. We influenced the district's comprehensive plan, have been able to add components into the different chapters related to health so that different parts of the small area plans, which is how each neighborhood in the district is designed, will have to take into account the health impacts of the design of those neighborhoods. We have been able to influence some of the health policies and some of the policies in certain agencies like the Department of Energy and Environment, the Department of Transportation, the Chief Resilience Officer's policies, as well as the Vision Zero initiative, and even establish more data infrastructure in our agency that facilitates many of these programs. The other thing that and sorry, I'll just show you all really quickly what one of the quick snapshots of one of the charts for housing in particular. We're able to show how life expectancy correlates with the percentage in the district specifically with the proportion of an individual's income or group's income they spend on housing, showing that the more people spend on housing, the lower life expectancy they tend to have in the District of Columbia. And we do this for each one of the 9 key drivers. By neighborhood. So this isn't by ward, it isn't by census tract, it's by neighborhood, which is what resonates most with residents in the district. As a result of our work, we were able to begin to influence some of the decision-making of our peers and colleagues in other parts of the government, such that budget policy was actually impacted in a way that different parts of the government started to see more resources be invested in things that we believe would influence health. So expansion of transportation options where certain city-funded public transportation options were advanced into neighborhoods that had less access. Some you all who live here, is the circulator expanding towards 7 and 8. Things like the Housing Production Trust Fund has parts of that trust fund that is reserved to expand access to assisted living opportunities that are accessible to the Medicaid population. So because we have a huge issue with individuals who are experiencing homelessness, who need access to housing opportunities, and they cycle in and out of healthcare facilities, or who have co-occurring behavioral health diagnoses and don't have opportunities for stable housing. And so increasing housing production geared toward those particular populations. And then a lot more investments in some of our violence prevention efforts that are not just related to law enforcement or criminal justice efforts, but things around our public health approaches to violence prevention with violence interruption services, trauma-informed care centers, and then an initiative called Families First that puts prevention upstream, focusing on providing the self-efficacy services that families need at a very early stage. But in terms of future directions, a lot of our conversations about health in the district get sidelined because of our discussions about the inequitable distribution of inpatient healthcare facilities. And if we don't pay attention to that conversation or give space for that conversation to happen, it sometimes becomes difficult for us to fully give service to the conversation around social determinants of health. There's a huge recognition about the impact of social determinants of health. People understand health equity. We've made a lot of ground around it. Anytime any entity publishes a report on variations in life expectancy, correlations between poverty and level of education and life expectancy, it gets lots of traction. But people still struggle sometimes to fully understand what it means to operationalize those things in the space of health. And they will focus on multi-million dollars, hundreds of millions of dollars investments in more healthcare capacity. And we have made those investments over periods of time, $70 million in investment in primary care infrastructure that no one uses, right? So we really have to figure out how to really get to addressing the healthcare access pieces in the district. And this is an important correlation to what the rest of the country needs to do as we have healthcare expansion that does not equate to improved health status for the population as a whole. So yesterday, the mayor announced a mayor's commission on healthcare system transformation that gives space for that conversation. You get 6 months, put some recommendations on the table. What are we going to do? How are we going to move forward? And the healthcare systems who are responsible for improving the quality of services, creating systems of care that are modernized, that create more equitable access, are the actual members of that commission. It's not a bunch of think tanks or advocates. It's the actual people who operate those systems who are responsible for serving on that commission. We also have to do a better job of leveraging existing community health needs assessments and community health improvement plans to actually inform what community benefit investment looks like in the district. We know that social determinants of health are critically important. We do all these fancy publications. We say we need more housing, we need more workforce opportunities, et cetera, and then we still spend our community development benefit dollars on health fairs or programs that already have insurance reimbursement. Doesn't make a lot of sense for a jurisdiction that has 98% of its population insured. So we really have to do a better job of leveraging what the data tells us we need to be investing in with the social responsibility and legal tax responsibility to actually make those investments. We have to continue to cultivate relationships with our business community. There's a lot of focus on the business community should be creating new technology products that allow people to better communicate with each other, because the whole problem is docs don't know how to talk to patients, or we can't send data to each other for timely transactions in the health system, et cetera. But the cultivation of business relationships shouldn't only be about that. There's a lot of things that the business community should be doing in cities to create economic opportunity for residents on a much broader scale. And the space for those conversations need to be ongoing. When the public health community gets in front of business, it shouldn't just be about health IT and cultivating health IT businesses so that they can thrive and you're creating more entrepreneurs. Our thinking needs to be broader than that. And then we have to further expand the public's understanding of health literacy concepts. The reason why we have poor health outcomes in a lot of our cities is because we've only talked about health literacy as you need to work out more, you need to eat more fruits and vegetables, and you need to know your numbers. That's what we say when we talk about health literacy, but we haven't really expressed to people that, yes, that's one part of health literacy, which is about your behaviors, but we don't talk to people about the literacy of navigating the health system or the literacy of understanding your health insurance, which is what bankrupts many people. So really expanding people's health literacy and recognizing that some people are just gonna remain at low health literacy, and what do we do about that? How do we create health systems that are designed to support our people who are at the lowest levels of health literacy? And the last thing that I will say is that having been in a city that is in a state, and then a city that is just its own thing, that there's tremendous opportunities to coordinate with federal agencies for high impact design of initiatives. We have had so many opportunities where we are not making the most strategic investments to to improve the health of our country by making those strategic investments or designs of programs where the resources are actually going where the pathology is. And if we continue to have that type of structure in our design of programs and initiatives, we will continue to have a level of pathology or a level of dysfunction as it relates to health outcomes that will leave us stagnant and in a place where we are. There needs to be economic investment in a number of places in our country. But if we're really talking about investing or creating programs and initiatives for the purposes of improving health outcomes, we have to invest, whether it be putting human capital or financial investments in the places where the actual pathology and problems are. So I'll stop there.
Wonderful. Thank you, LaQuandra. Wonderful. And we're now turned to Sarah Rosenwortel, who will provide remarks, and then we'll get to some discussion. Some great themes emerging across all the presentations.
Right, indeed. And in fact, you guys made my jobs a whole lot easier because I just get to point to things that other folks have said. I'm Sarah Rosenwortel. I have the honor and privilege of being the president of the Urban Institute, which, if you don't know, we're a social science research organization, does a lot of analysis of different problems, but also increasingly we have teams that we call research to action teams who are really working alongside change makers in different communities that are tackling problems using data and evidence to help them accelerate solutions. And so we work with lots of, whether it's local government officials or philanthropy or business community or community-based organizations to help them advance solutions to many of the issues that have been raised here and work on different issues in each of these cities and many more. I think the first thing I would say is, would that every city was Chicago and DC. What you just heard is two of our nation's cities that in different ways are amongst the most sophisticated about thinking around strategies to advance health through all kinds of different dimensions of policy. And these are, in some ways, some of these are strategies that have been in place for decades, and in other ways, there's been very significant evolution in understanding and sophistication of these strategies over the last few years, in part because of the leaders that you just heard from, and their mayors in particular, and what they've focused on. And I'm going to talk about, in a few minutes, a few of what we're seeing at Urban as we look at cities all around the country as best practices, and almost everything I'll mention you heard described in some facet or other there. I worry a lot, and you heard them talk about the profound degree to which cities are amongst our healthiest places in our country, but within those cities, we have enormous understanding now of the degree to which there are communities of opportunity and communities where opportunity is very close by, yet very hard to find, and so many different dimensions of opportunity align in those places. And we're going to hear more about it. I worry also about the cities that are far away from having the economic engines that these cities both have that then bring their public institutions, resources. They have growing employers. They have anchor institutions who are healthy and who are able to invest, et cetera. But you think about the parts of this country where you're seeing declining populations, smaller sizes, less data, sophistication, less resources, and then the problems that we just heard talked about are magnified. A couple of observations. I'm going to talk about a couple of strategies that we see many of these cities using, and I'll use as examples housing, community development, and investment of capital. But I could be talking about Urban has teams that work on criminal justice and safety and health and education and employment. And interestingly, all of those strategies, if you looked at some of their pictures around the different systems that are important, I could be just as well picking up on those. I'm a houser. I forgot to do my little bit about me, but I'm a lawyer, a recovering one, but a public policy geek. I worked in the Clinton administration at both HUD and the White House, and have been then a serial think tank entrepreneur, and so have been leading. So I know a little bit of everything, which means I know not much well, but to the extent I know one thing really well, it's housing policy. So you'll see a little bit of bias in this. So let me just mention two things about why housing and community development really matter to the outcomes we were talking about. And then I'll talk a little bit more about modes of work that make these strategies successful. So the first thing is that obviously, we on average spend 70% of our time in our homes. So what place matters more to the likelihood of health outcomes? And we know not only about how the physical condition of your space can trigger things like asthma and other things that affect housing, your health, but we also know how the stability of your housing and the environment your housing is in can affect health. So think about the ways in which children who grow up with repeated trauma and stress living in less safe communities, or where their families find themselves subject to frequent eviction and lack of housing stability, the ways in which that affects the healthy development and mental health probably don't have to be explained in this room. Similarly, if you live in neighborhoods where there are vacant housing nearby, or the lack of access to parks and communities, people who have less physical mobility because their safety depends on that, the other ways that affects housing. And as I think has already been mentioned, there is a growing body of evidence that simply ties housing unaffordability to health outcomes. If your family is spending 50, 60, 70% of their income on paying the rent, they're not spending it on other things that are likely to make for better health outcomes. And so there are a lot of strategies that our cities are starting to make to investments in creating well-balanced, affordable housing that are going to, I think, in many ways, pay large dividends on the kind of health outcomes. We tend to think about those things, and where the science is best is in showing the relationship between the investments in housing and very vulnerable populations like veterans and the homelessness. The evidence case there for spending $1 to house somebody is off the charts. You really don't need to spend a lot more time. I think we're going to find the more we spend time is that having access to affordable housing for the broader population as a whole is going to pay benefits for health outcomes. Also, we know that where you live and the degree to which you live in a community of opportunity affects everything: economic outcomes, affects health outcomes, which goes to the question of how we sort ourselves in where we live. And one of the great things we've learned is that residential segregation is one of our profound legacies of our city, and the ways in which our history of racism is baked into every aspect of the way people live their lives. And those, we recently did a study in the city of Chicago that looked at where capital flows today. And capital flows into white neighborhoods at rates even when you control for home ownership and other things, at 3 or 4 times the rate in which they flow into minority neighborhoods in Chicago. And those, if you were to look at those capital flow numbers and look at the numbers we saw about longevity, guess what? They're perfectly correlated as well. So there's a set of questions around the built environment, around residential segregation, around access to communities of opportunity. We also know in cities that are rapidly gentrifying, or have neighborhoods that are rapidly gentrifying and have a lot of growth, like all 2 of the cities we've talked about here, you have neighborhoods that are actually rapidly becoming getting more access to opportunity as they are, and it is a lot less expensive to help people remain in places that are becoming more opportunity rich than to try to find a way to move somebody into a high income neighborhood. And so finding ways, as there is growth going on, to do housing strategies that allow people to remain in those neighborhoods and to have access to affordable housing and create more mixed income communities, I would argue we will find in time are very important health enhancing strategies. I guess the only other thing I would say on housing, we did a study also in the Chicago metropolitan region, and comparing Chicago to regions all around the country and looked at the degree to which segregation has effects on other dimensions. We called it the cost of segregation, and found that if you take a look, there's a strong relationship between the degree of segregation and the net amount of economic growth that a region overall has, but there's a correlation between the degree of segregation and the number of gun deaths, for example. In other words, a community that is just more racially and economically desegregated often has lower rates of violence. And so we found, I will get the number, that if the city of Chicago had been as racially and economically integrated as the average metropolitan region in the country, 167 more people would have lived in 1 year than with the death rate in Chicago, which has sort of been a bit of a gun violence death rate, been notorious. So equity physically or inequity physically maps itself on our communities in ways that have health outcomes. Let me just talk for a moment, in the interest of time, about the way in which we can, every one of these different policy dimensions, you can approach these problems, and you heard it being described here. So let me just lift up a couple of things as best practices. The first we heard about is these are two cities that are being incredibly data-driven in their results, right? They have indicators, they are managing them, they're providing accountability and transparency, they're telling everybody what they're trying to move the needle on, and then they get red, yellow, and green lights as to whether or not they're doing it or not. And if you're a mayor, you know that gives you a lot of gulp moments if you promise to move those needles and you don't know if they're gonna 2 years hence. One of the things we found, we work with networks of data intermediaries all around the country. It is important that the cities be integrating their data and making their data public, but it is also important that there is a rich, sophisticated ecosystem of data consumers in a city who interact with the city and can push on these narratives and can help the city build strategies that are not just governmental agencies, but involve all these other partners. So building a data sophistication and capacity in the larger community of advocates who can not just know the health data or the education data or the housing data, but know them all together is a key indicator, I would argue, for places that are going to be able to make progress on some of these things. Another strategy is building with the communities, not for the communities. And you heard that described in all kinds of different ways here. Here in DC, we're doing work with an organization called BBAR, Building Bridges Across the River. The neighborhood that is lacking in health system provider is the other side of a very large physical barrier, but it is lacking in a number of other economic investments as well. If you're thinking about building a large public amenity, a park, in this case the 11th Street Bridge Park, which you could imagine, if you think of it as a high line you can't get off in the middle, could be quite transformative to these neighborhoods. How do we think well in advance of that about the capacity of the neighborhoods on the other side of the river to be able to, the incumbent residents to be able to benefit from the gains that that neighborhood will see from economic activity. So we're trying to think about how do you plan that well in advance of building that bridge park, and how do you make sure that they are tenant ownership, resident, same set of analyses can go to public health as you're thinking about getting the local residents to plan the economic development strategies. Another key strategy you heard people talk about here is engaging your ranking institutions. Those 8 health systems that are 6 health systems on the west side of Chicago, they're not only health providers, they are employers, they are consumers of product from the neighborhood, they are large economic engines, and to the extent to which they are part of health strategies, we just convened 10 of the nation's largest, largely nonprofit health systems who are focused on investing in housing, because more and more, whether it's, you see doctors actually even sometimes for their patients prescribing some kind of housing remedy, or it's because they have to invest their community in dollars in their community, and they realize that if they invest it in affordable housing, that may pay, they stop seeing uninsured repeat customers, other solutions that will benefit the health system as well. So involving anchor institutions, and particularly health systems, is an important one. Another thing is about voice. Those institutions can become a voice for health policy outcomes or housing policy outcomes or other outcomes that may, you think, a little far afield from what a hospital might care about. But if they become a voice claiming public resources for housing, it becomes important to the change. And then I guess the last thing I would argue is about proximity. In other words, we think a lot about a health system goes and builds it, determines its locations, and then a social service job training program is coming and thinking about where to locate. And all these decisions happen in separate silos, but it is very often the case that when you co-locate access to different kinds of opportunity, health and non-health services, we're seeing that some of the best synergies are there. So everything I just said, these cities in different ways are doing, and I think represent some of the most promising things we can think about for the future. Thank you.
Thank you. So a fantastic set of comments, and I'm going to get us started on the conversation. But again, I want to encourage you, there are microphones. I'm going to probably do a couple of questions, but really want to encourage you to come up to the mics. That'll be a signal to me that there's appetite, and we can alternate between the audience and us. So please join us in the conversation. So one of the things that really came up across all of the presentations in different ways and is so much more prominent in at least national conversations that I'm part of or hear is this emphasis on social determinants of health. But for public health, and my first real job, I like to say, after my residencies, was in a state health department. So, and I'm a pediatrician. So it's like, I kind of knew that in the 80s, like what's new? So I guess I want to ask, is this shift, is it real? Are we going to see traction? Are we going to see the kinds of, are we going to see the spread of the kind of collaborative partnerships that you are forging as leading cities tackling this? And if not, what are the remaining barriers? And what are you worried about in terms of actually achieving action on social determinants of health in cities? Any of you can take this.
For me, it's a loaded question, and I had a similar reaction. My decision to pursue the additional degree in public health was based on the same thing. It was like, duh, right? Your patients are coming in, they have the barriers that don't allow them to do what you're recommending that are all completely related to their social circumstances. And I think many people who are trained as clinicians get that. But what I see as being more encouraging is just in the past 10 years, I've encountered more people who are trained as professionals in transportation or education who are in their own space being motivated to make policy decisions that are pro-health. So even if the health official in that community isn't really interested in playing nice with other sectors, those individuals in those sectors are making policy decisions in transportation, in planning that are pro-health. So for me, I see it as being we're more on a road to permanence around the social determinants transformation than we have been in the past. Where I'm less assured is if we are doing it for the sake of achieving health equity or race equity. I do feel a lot more comfortable around it from the, we are doing the right things in the social determinants of health. I feel a lot more confidence around, people are doing things that are pro-health and livable, walkable, et cetera, because people just want to use active transportation. People don't want to drive for long periods of time to get groceries, right? But if they're doing it because they want to help achieve health equity or race equity, I'm not sure that that's the motivator.
So it's interesting, I'm a pediatrician as well, and have spent the majority of my career working on infectious diseases. And when I accepted this position as commissioner, I thought, oh my God, what am I doing? Because you know, with infectious diseases, you have vaccines or you have antibiotics, and you know there are evidence-based interventions that we know have worked, and we just need to get them out to the right people, and we can get this done. When you talk about addressing social determinants of health, oh my gosh, this is such a big, it's such an enormous problem that needs so much coordination and collaboration, and so I wanted to flee. But I've just loved it, because I think what has happened is there is this readiness on the part of our other sectors to address these issues and work with us, which is, I don't think has been there in the past. The other thing I think is important to acknowledge is the Affordable Care Act actually freed us up to do this. The Affordable Care Act allowed for so many people, many more people to get insurance and to be covered, that public health didn't have to think about that as much. And healthcare systems don't have to think about using their community benefit to cover uncompensated care. We're freed up to think about these things in a way and have resources, have attention, enough bandwidth to think about these issues, as well as resources to put toward them that we can actually address them in meaningful ways. So I feel like there's an opportunity that became available because of the Affordable Care Act and other things as well. So I think there is a readiness, and I actually feel a huge amount of momentum. ASTO, which is the State and Territorial Health Officers national organization, they have one of their President's Challenge relates to determinants of health. The prior year, it was also determinants of health and health equity. So the momentum is there, and there's a lot of conversation. What I fear, though, is that public health departments, 80% of my budget in the city of Chicago comes from grants to do lead prevention, to do immunizations, to do emergency preparedness. It's not there for us to build the capacity to address race and health equity and to address determinants of health. So what we're doing right now was, from the 20% of our budget that comes from city dollars, we've prioritized cross-sector collaboration, addressing determinants of health, deconstructing racist systems within our department, joining GARE so that we can actually develop systems in our own government agency to prevent perpetuation of racist systems. So we're having to use the small amount of money that we have in our budget. What thrills me and what makes it really hard for me to leave the city of Chicago is that Mayor Lightfoot said, your department is under-resourced, you need more money. And I thought, oh my God, why am I leaving now? So I feel like there isn't, she said, maybe not this budget season, but in the future we will. Give us your ideal state. So boy, we've had a lot of fun creating our ideal state. But I think there is this, what I fear is that CDC's funding does not allow for us to focus on determinants of health, race equity, health equity at all. And that is where the majority of our funding comes from. And if we don't get resources from other places, we won't be able to take this work to the next level. And we really do need to take it further.
Great. Sarah?
I was going to make the point about silos and how funding comes in silos. So it's not just the public health dollars that aren't flexible, but that, transportation dollars and housing dollars and all those other dollars have their own imperatives that don't do very well in these coordinated systems, which is one of the reasons why this is a bit of a golden moment, because you do see both private sector institutions that are flush with tax refunds that they are trying to figure out, and very worried about the growth inequities in our country, if only because they're worried about political backlash from those inequities. And so they are trying to find ways that they can contribute, and contribute in places that are important. And so they're putting some resources in. When the economy is less healthy than it is today, that dividend, such as it is likely to dry up. And that is, I think, local philanthropy and local corporate funding is sometimes paying for these collaborations. The other thing I really worry about is that the energy here is local. And ultimately, scale comes from being able to work at larger systems levels. And I don't see the creativity and energy coming in the political system in Washington. We all, paralysis, all that stuff. So it's much harder to get leadership that can be reinforcing of these strategies from the federal level right now. And I don't know, again, my point about which cities are able to make progress. It's great to have the role models. It's great to see it. But to spread that wide is going to require leadership at the national level.
Yeah, and I wanted to jump in just to say, we've been interviewing mayors for many years now, and we've heard from them. I obviously made the point that they're using the language of health, they're using language like social determinants, but even beyond that, they're identifying common challenges rooted in social determinants. So when we've asked mayors, what's the number one reason people leave your city? housing costs, not schools, not jobs, it's housing costs. When we've asked them, which are you more concerned about, poverty, inequality, or the shrinking middle class, they will say poverty. What's the population you need to do more to help? People living in poverty. But there's one blind spot, and I'm a booster when it comes to mayors, but there is one blind spot. Mayors, we had published a report last year with the National League of Cities on mayors' perceptions of racism and discrimination in the country and in their cities. And they see widespread, and they recognize, Republicans, Democrats, men, women, they recognize racism and discrimination. Where they fail to see it is with regard to inequity in the quality of the built environment. And we thought, okay, let's double check the data, this has to be wrong. But mayors don't recognize inequity in the quality of white neighborhoods compared to neighborhoods of color with regard to streets, transit, and parks. They only acknowledge it with regard to schools, which the majority of them actually are not responsible for, because very few cities are like Boston or like New York where they have direct responsibility over the school district. So there's one opportunity where I think big cities are leading, but there's one opportunity both to be more data-driven and to help remedy that blind spot for mayors, and that really is to help them recognize and acknowledge inequity in the quality of the built environment, and that means inequity in the quality of streets, in the quality of sidewalks, in the quality of parks and playgrounds, the kinds of things that help promote health. So I think mayors are, I just want to reinforce, for mayors are strong allies. They see a lot of the underlying causes. They recognize social determinants even if they don't use the label and they can't name them, but there's a key blind spot that the public health community can help to remedy.
Great, thank you. So we have some questions already, so I want to please introduce yourself and ask your question.
Hi, I'm Jane O'Donnell. I'm a health policy reporter at USA Today and the founder of the Urban Health Media Project, and one of my students is here with me today. You actually set up my question nicely because you brought up inequity. One of the biggest areas of inequity that I cover is in quality of care and the safety of the hospitals, and the hospitals in the areas that treat the low-income people with the shorter life expectancies have Ds and Fs. So I wanted to ask Dr. Nesbitt in particular about, you mentioned, I mean, on one hand, it certainly is a tragedy, perhaps, that United Medical Center's maternal care facility is closed, but that's an F-rated hospital. What has the DC Public Health Department done to improve the quality of Washington Hospital Center, which is a D-rated hospital? Howard goes back and forth between a D and an F, and I'd also be interested from the commissioner from Chicago to talk about, you know, what public health departments can and should be doing to improve the quality of care and the safety.
So I'll set the stage at a high level, and then I will answer your question, and then maybe, if not to your satisfaction, we can talk offline. One, most cities don't have the responsibility for regulating hospitals and healthcare facilities. That's typically a state function, which is where I come in as an oddity. Two, healthcare facilities have the option of actively participating in the reports or passively participating in the reports. And sometimes their grade is a function of their active or passive participation. So as a health director who actively regulates the facilities, I don't necessarily comment on those specific grades, so I won't do that for you in particular. I'm more focused on what they do with our actual licensure surveys, which are a state requirement, which we do every year annually, and then we also act as the designee for CMS, or the Center for Medicare and Medicaid Services. We have been very committed to improving patient safety and quality in the District of Columbia. It's been a huge focus of mine, and I've worked collaboratively with the DC Hospital Association and all of our hospital executives and leaders. I'm with them all the time. I actually went to their annual Patient Safety and Quality Summit last year to help reestablish some of the primary goals that we have. From my perspective, sometimes having access to something can be worse than having access to nothing, right? And that's where my decision-making comes in. We have to recognize that in healthcare, that volume and quality are inextricably linked. And sometimes the decisions that we make around access to particular service lines have as much to do with the volume of those services that a particular healthcare facility offers as it does to the quality of those particular services. So any of the times that you are looking at grades from a particular organization, you have to actually know whether or not that healthcare facility is an active participant or a passive participant in
It's
that
the same with
survey.
CMS, though. I mean, Leapfrog uses CMS.
Correct, but there are
both
other
ways there, too.
supplemental data points to Leapfrog beyond CMS. And so if you participate actively in Leapfrog, that impacts your score.
But you won't get, you actually won't get a lower score if you don't participate.
Possibly. So, and we can talk offline about that.
And I'm curious, I noticed the ratings seemed a little higher in Chicago.
So as
And you're not
LaQuandra
regulated.
mentioned, we don't regulate the hospitals. The state health department regulates the hospitals, so we don't do that. But it's kind of interesting. It's emblematic. What I'll say is that we do interact with the healthcare systems pretty closely on select issues, which goes back to the siloing of our funding. So we get a lot of funding to do immunization work. We get a lot of work to do healthcare-associated infections type of work. We get funding to do restaurant or food established food preparation inspections. So we're in healthcare systems, guiding them, informing them about their flu vaccination programs for their healthcare providers. We're in there looking at their infection control practices to prevent healthcare-associated infections. We're in there inspecting their food, their cafeterias and their food chain to make sure that but we are not actually responsible for giving them the grades or evaluating their performance. So most locals are not responsible for that. But we do have an ability to impact the quality of the work that they're doing within their institutions, but it's based on the funding that we get, which is very, very siloed.
I didn't know that about infections. That's interesting. Thank you.
Great. Turning over here.
Thank you. First, thank you, spectacular panel. I'm Kitty Shidana with the National League of Cities, and very interested in seeing Catherine's data, in particular the emphasis on what's behind the emphasis on health. We just published our State of the Cities report for 2019, and health moved up from number 7 to number 3. And a lot of what's behind it is about parks. So I think there's a little bit, but I think that's related more to the obesity issue, and we hope that it will be generalizable in the right direction towards greater built environment. I was particularly interested in both Dr. Nesbitt and Marina talking about your data, the data hubs that you've made publicly available. One of the capacities that many cities are developing is authentic community engagement, and very often the use of data to communicate with and to start conversations with real residents in the community, not just the grass tops, I think in many ways builds the political will for longer term, more sustainable change when elected officials change and sometimes city staff change. So I'd like to hear your experience in terms of applying those, the data atlas, our Healthy DC, to have conversations with residents and have them reflect on priorities of the city.
So the Chicago Health Atlas that we created was released shortly after we released our Healthy Chicago 2.0 plan. With both the plan development as well as with the Chicago Health Atlas, we then shared them with the public. So they have an opportunity to look at what it is that we had identified as health priorities, what disparities we'd identified, what challenges we wanted to embrace in our approaches and get their feedback. And so it was really a helpful, useful process for us to be a part of. I don't think we did a really great job. I mean, I don't think we do public engagement really well. And so over the past few years, we really intensified our efforts to engage with others who do better community engagement, true authentic community engagement. We often will do a report or ask for input, but it's just not the real thing. And so one of the initiatives that we are a part of most, in the past couple of years is this SPARK initiative. It's Strong, Prosperous, and Resilient Communities Challenge. And it's a transit-oriented development initiative. And in Chicago, we're doing it, it's become an equitable transit-oriented development initiative. So we're looking at 4 different communities, the communities that with low life expectancy that I showed on our map, and 7 of the train stations there, and developing the half-mile radius around those areas with arts and culture, with health in mind, with environmental protection issues in mind, and then, but also really in an authentic really community engaged process. And the groups that are leading the initiatives are from the community. And so their planning and their voices are part of really creating what the plans were, and the work is really reflective of what their priorities and what their desires are. And it's been an incredible learning experience for me. As I'm leaving the city, I'm getting all these gifts, and this group actually gave me their community engagement binder and said, take this and use this when you go to Robert Wood Johnson Foundation, because we've learned so much through their process. And I think it's a great example of how we're all talking about it. Public health is talking about this need to do authentic community engagement. Are we well prepared, and do we do this well? Well, we don't really get much funding to do that. And so these kinds of initiatives that really push us and allow us to engage with those who are experts in the field really help us to take the work to the next level. But I think you're right, data really help us to engage the community because it's valuable to them. They want the data to inform their applications, what projects that they're doing, or how to prioritize the work within their communities as well. So we are so glad to have our Health Atlas out there. And we have staff that will go out and do training for the community so they can understand how to access that data, and then how to interpret the data and how to use the data as well.
Can I just mention one? I'm sorry, go ahead.
So we have I would say it's still a work in progress for us for a couple of reasons. We're often challenged with figuring out the best way to make the data available so that it is appropriate for multiple audiences, right? So the district has this open data executive order where we have to publish as many data sets as we can. Every agency has to do this so people can use it. But I think that is really geared toward people who want to make an app for that, right? So they want to use these open data sets to try to code something and then sell it back to the government to say, I can make you an app that can make all the hotspot. And I'm like, well, we have 7 people who work here who can also make a hotspot, right? So we know where the problem is. So there's that way of making the data available. But then we have these data portals and the way that we publish the data just to put it out there to say this is the progress that we made, and that appeals to some people. But we're still getting overwhelming numbers of data requests by our academic partners or data scientists who want something more customizable or something that they can manipulate, et cetera. What we have been able to do to drive more community interest, because the community has their own ideas of what they believe the problem is, that they are still disconnected from the actual data, right? And their understanding of what the problem is may be from 10 years ago, so they haven't checked in on the data. So what we've been doing is we drive them toward, what's the healthy people indicator you are working to impact? So that's one way we've been forcing people to actually go look at the data, right? So they have to tell us, and it can be even for our mini grants. We know that they're not going to move the needle substantially, but at least people are going to look at the data. They're picking an indicator that they're trying to impact. So anytime you're submitting for funding from us, you've got to go and you've got to touch that data. You've got to play around with it. You've got to have some level of familiarity with it, no matter how advanced the organization. And then people have to actually shoot that back to us with their evaluation plans, et cetera. But I think we still have to mature a lot in terms of putting the data out there where it's in the most useful form for a key number of target audiences.
Just one thing I'd observe is that residents often of a community actually see data and see the insight in data differently. So in the research mode, for example, it used to be that we would come in and we'd collect information, we'd go home and we'd decide what supposedly that told us. But it's a very different process. We did this recently in a couple of DC housing projects where before you start the research, you sit down and you talk to the residents of the community about what question we're asking. And guess what? The question starts to adapt and change if you are understanding the question that's relevant and important from the perspective of the residents that you're studying. And then you use the residents, ask them to be part of the data collection. And often you get richer and more nuanced and important data because the people collecting it look different and they are of the community and there's a different level of trust and you get more fulsome answers. And then you sit down and you say, okay, well, we're going to interpret this data. And it's not only what the scholar, again, back in our offices is thinking, but you find all kinds of interesting insight. We found interesting patterns of behavior in certain projects, and then we found, well, we were finding the behavior was changing later in the month. The residents understood that had to do with timing of food stamps being issued, that that our scholars who were studying sexual behavior didn't think about food stamps, right? So having the residents be part of the data interpretation told us something new. So I think there's lots of different ways in which interacting, it may not be the city's job in releasing its official data, but in ways we start to understand how different lived experience is evidence too, and combining lived experience with these more formal collection methods gives us a much more rich understanding.
Thank you. Before I turn to the next question, I'd just like to comment on this as well, because the data is transforming our ability to interact in a more effective way. And you each talked a lot about the importance of policy and systems to scale and spread effective approaches. And I'm recall the comments by Bob Ross, Dr. Ross, who runs the California Endowment, reflecting on his first years of the Building Healthy Communities initiative in California, where, again, the philanthropy and the initial thinking around what they would do really evolved over time in terms of what the priorities would be as they worked with communities and they gave communities voice. And so priorities shifted to more social justice and criminal justice reform and other issues, but at the same time they work at the policy and systems level. So that pairing of community voice and engagement with the policy and systems ability to then react and act on it, I think can be very powerful. So thank you for that. And I need to mention that actually in the last 2 years that we've done an award at a conference called Data Palooza, so guess what, it's about data. The two winners, we do this award with the Milbank Fund for State Local Innovation, and the winners in 2018 was the city of Chicago, and this past year the city of San Diego for Live Well San Diego. And again, prioritizing what one city has done, certainly Live Well San Diego, and developing templates and tools that other cities can use to replicate how they operationalized and made their data available for decision making. So I'm going to turn here to the next question.
Great, thank you, and thank you for this panel, and thanks all of you for the incredible work that you do and have done. Cities are just amazing laboratories for change. There's so much that we can do at that level. I'm David Jernigan. I'm a professor at Boston University, but I also spend about half my time working on City Health, which is an initiative of the BEAUMONT Foundation and Kaiser Permanente that has selected a basket of 9 policies that address social determinants of health, and then we rate the cities and we thank them. And it's great to have a silver and a gold medal city right here. It's been really interesting for me working across all those 9 policies. They are designed to address social determinants of health. And we have one bucket that's about public safety. And the policy we selected there was local control of alcohol outlets. And alcohol is something I haven't heard mentioned anywhere. It didn't show up in any of your word clouds from your polling. From the health side of things, we're seeing increases in ED visits attributable to alcohol. We're seeing pretty dramatic increases in high-risk drinking among adults, not kids where the focus has been, but adults, with the gender gap disappearing, which is problematic for alcohol because women will suffer more from alcohol, from the same amount of alcohol than men will. This is also a health equity issue in that we've done a lot of work on alcohol outlet clusters in Baltimore City, found that controlling for all sorts of other things, one of the biggest predictors of those clusters is a history of residential redlining. Alcohol will make any set of inequities worse. So I'm just curious, and I wanted to ask your panel, why is alcohol absent? Where's the alcohol conversation in terms of health of cities? We're hearing a lot on the other end of alcohol is going to be, we need more licenses in the downtown district. We need more, more alcohol-built environments so we can have these thriving downtown entertainment districts so that our cities will do better economically. And I'm just curious about your thoughts about where's public health in the alcohol conversation. Thanks.
I feel like I'm a broken record because what I'm going to say is that a lot of the work that we prioritize is based on the funding that we get. And so the opioid epidemic has driven a lot of funding, and so we're able to address that substance use disorder challenge a lot more aggressively than we can with alcohol because we have resources that are coming our way from the federal government. So I think I've never, as long as I've been at the city of Chicago, I'm not aware of any funding coming to us to work on alcohol. And so and the 20% of our budget that is from city dollars has not been prioritized to do that work as well. So I think part of it has to do with just the resources that are available to support the kind of work that we're doing.
One of the things that has been interesting and I'll answer it, continue on the conversation around the opioids piece, is that the focus on opioids has highlighted a lot of the ways or differences in terms of how behavioral health conditions and the policies around behavioral health conditions with alcohol, tobacco, and other drugs being funded in this country is very different and very peculiar. So what typically happens, except for in Washington, D.C., so I'll give you my rationale for what's happening here, is that the funding comes to the state level, and then they pass it out to the cities and counties. And they do it in a way where they, for some reason, they try to rationale where the dollars and resources are going. In the first pass of opioid dollars, I think Julie got nothing, right? And then we had this very interesting meeting at the CDC. And then Julie got something. So,
Go, Julie.
She might tell the story a little bit differently. But what has happened is that funding for substance use disorders in this country has not really gone to local health departments. Even for those who are under municipal control. They have gone to community mental health centers. And therefore, the policy radar for many elected officials, it's been nil for behavioral health, right? So there's been a huge advocacy agenda for behavioral health that is focused on parity with mental health, physical health services. So it's only been about access to care. Yeah. So we focused on tobacco sales, 18 or 21, raising tobacco tax. Elected officials can get on board with that because there's some, right, every now and then some cash related to that, and then we get involved. We get involved in the debate to say, will that revenue be dedicated to health services or not? In the district, we sort of have the same phenomena because we fractured all of our health agencies out, right? So we've got 3 different health agencies: healthcare, finance, behavioral health, and then me. And then we had this interesting situation where maybe there was going to be a merger of behavioral health and not, and then I was like the director of both for a time. And so the conversation kept happening, and I was pointing out for people, well, in most cities, there's no funding goes to these behavioral health issues, and there's no discussion around policy. The other caveat to that is while most people would see in their jurisdictions that alcohol retail location density there's a correlation with the binge drinking, the high consumption of alcohol. In the district, our binge drinking tends to happen in our higher income, higher education population. So every year in our BRFSS data, that's where we see our higher consumption of alcohol.
You're not alone. That's the group that drinks the most, but the outlets get concentrated in the poor neighborhoods.
Yeah. Not necessarily. This is not a pattern that is always seen in urban areas. So if I go to my elected officials, and some of them have become data-driven, they're gonna be like, so is this really a problem we need to take out of low-income communities where educational attainment is low? They may have more outlets, but they don't seem to be drinking, right? So that's the sort of the logic that they will follow. And so then there we are, right? So
I can help you with that logic.
Yeah. So that's sort of where we are. So in the grand scheme of alcohol, tobacco, and other drugs, and the diseases of despair, which is how we're having a conversation about them in public health, it just keeps falling to the bottom. And now we have marijuana to contend with.
Yeah. So I wanted to add something too. I think part of the siloing of the funding, the siloing of our work, we could really flip that around if the funding became more flexible and we could really use resources to look and address social determinants of health. With the opioids in particular, there's an opportunity to say, you know, the reasons that we're having, part of why we're having this problem with the opioid epidemic goes back to these root causes of health. It's the diseases of despair, like in these communities, in these geographies, in these subpopulations of folks that are really struggling right now. If we lifted up these communities from an educational perspective, from an economic opportunity perspective, improve the housing opportunities, we improved all these factors, everything, chronic disease, substance use disorder, mental illness, those things would all improve. And we could, so the funding, but we're not able to think about it in this holistic kind of way because we're so siloed in the, we have to do our grant deliverable. We have to achieve X number of, I don't know what, I'm gonna make something up, outbreak investigations by, you know, per year. If we're focused on our work in that way, we're never really going to get to the point where we can think more holistically and address all these problems at the root level.
If I can just
So
follow up
I-
real quickly, Dr.
Well, we
Lusk.
just
I
have
was
5 minutes left,
Okay.
please.
Okay.
I
Thank
just
you.
want to get to our last 2 questions, if I may.
Thank you first, actually.
Oh, sorry, good, you kept track, please, you're next.
My name is David Aylward. I'm privileged to be leading an effort in Colorado to try to combine primary care with social determinants. I work for a group called the Salud Family Health Centers, and so I'm going around the country trying to find the best ideas to apply there. So thank you for the incredible free consulting. I really appreciate it. Well, the problem, or a problem I see, is that the business model is wrong. We pay people to in ways that cause them to build enormous towers and fill them with sick people, and they make lots of money doing it. And so the medical establishment in Colorado is on this campus east of Denver with 3 hospitals and all these schools of medicine, and we have partnered with the School of Medicine to do this project. But are you aware of anybody around the country who is looking to compensate, to pay a provider group or group for keeping people well? Because it struck us that to the extent that we could be paid for, not for visits, today we're paid on visits, and so we do lots of visits. If we were paid by metrics of being well, we would have an incentive to go pay for housing, and not just the emergency room use every week by the homeless person, but the medium-term housing. So I just wondered if you see around the country, I know Urbanist is working on Pay for Success, which is what I'm talking about, but if you're aware of those kind of models around the country.
So one of the things, I'll speak to that briefly, is that since the Affordable Care Act also funded this Center for Medicare and Medicaid Innovation with $10 billion, there's been a big focus on payment models. Now, the first many generations were about building accountable care organizations, still much more on the clinical side. But I can't remember, Ed might remember, when the Accountable Health Communities model came out, which is, again, trying to move this financing stream of the insurance dollars towards more accountability for healthcare providers for broader outcomes. The results aren't in, you know, that's happening, developing. Also, then there were the state innovation programs that they launched, and some of those were really trying to move, again, towards more community population health. And there's a third area I was going to mention, now it's escaped me, but I can talk with you offline and connect you to folks, and I'm sure there are other experts in the room here, where folks are really trying to move in that direction. But until you really stop paying for fee-for-service, for volume in the healthcare system, and move towards value, and a greater proportion of the market is under a value incentive, and we have adequate measures that appropriately risk adjust for risk in the population, et cetera, it's, you know, we're sort of in the mode of learning right now, because, for example, all the payment incentives for reducing rehospitalizations and penalties for, you know, hospitals that had higher readmission rates, you know, they've been evaluated, the data's been coming out, very variable performance with a lot of upcoding by the hospitals, which accounts for a lot of the reduction in rehospitalizations, not true health impact. So the good side of this is that there is change. People are trying newer models. There's more potential incentive than there has been to date. And the last thing I wanted to mention was the Medicare Advantage. The rule last year now allows Medicare Advantage plans to be more flexible in what they will do with their insurance premium dollars, and some of them are moving towards addressing social determinants of health. So as we start seeing this chipping away, and Medicaid has always had a degree of that flexibility. You've mentioned housing time and again. A lot of Medicaid programs are trying to pay for housing. So I'm seeing more of it than I've ever seen before, but it's
The
not taken
one
away.
observation I'll make, and this is not an encouraging observation, is that increasingly our society is building two different systems of lots of things, one for the very, very high end and the one for everybody else. Recently I tried to call a doctor, a provider I liked, to see if she would start seeing my daughter, and well, no, she's gone into some concierge service now where I pay, $3,000 a year, and then I get an unlimited set of services. That model is not going to be available to the populations we're all spending our time working on worrying about now. So to your point about what are the business models that will do this at scale across the public sector has got to be part of it. Very early.
I agree. Last question.
I'll be fast. That was a good segue. Robert Longyear, Institute for Medicaid Innovation. I have a question. That was good. Not CMMI, different, private. So my question is, what does the political climate look like to start using healthcare funds to start addressing housing? So you can't use federal match funds to pay for housing. What does the political climate look at the city level, and the willingness to take that on?
Go ahead. Why don't you go ahead and talk to the city?
So it depends. There are some jurisdictions, well, I'll say here, we've introduced legislation that changes where we have a requirement for all of our health systems that get a certificate of need from us who have a requirement to spend 3% of their operating revenue on uncompensated care. Well, because so much of our population is insured, we want to change that 3% requirement from uncompensated care alone to uncompensated care and community benefit, and emphasizing that community benefit should include community building, for which a portion of it is investments in things like housing. We have a hearing on that legislation on June 26th. So we're very optimistic about it. Our health systems do have some concerns about the legislation because we are regional. Many of our healthcare providers, are regional. The first time we discussed it with them, they said they still had a lot of people from Virginia who were uninsured. Well, Virginia now has Medicaid expansion. So we're like, so who are you providing this uncompensated care to? So we're really optimistic that we can now get more alignment with what some of the social needs and the investments are around that. But our elected officials they have been asking for the past 7 years, like, why is there uncompensated care in the district? Everybody's insured. So they really want to understand it, and they're looking to see where the other investments could be and how they could be aligned to support some of the more global things. So we've worked a lot with some of our academic partners on helping to define community benefit and community building as a component of community benefit.
I'll just make an observation that this is there's interesting pockets of openness, but the evidence base isn't fully there that building 2 more units is going to get you to a different community health outcome yet. And in fact, even in the last administration at HHS, you did see sort of jealously as domestic discretionary dollars were going down for things like housing, that the healthcare people were saying, sort of hands off, right? We have health outcomes we want to worry about here. You housers don't go seeking after our resources. So, we have work to do. I would separate that out for veterans and homeless and some of the others where I think the case is clear, and we only see nonprofit and socially oriented healthcare systems really being the ones that are investing at any real scale in housing so far, but they're building a gradual evidence base that hopefully over time will create momentum.
Great. So on that note, thank you. First, a round of applause for our speakers. And now I want to hand it back to Dr. Galea, who brought us all together, and give us some final words.
One of the great privileges of being part of an institution that one of our core jobs is to convene people, is to bring people together like this to learn from them. So it's really a privilege to learn from you all for the past 2 hours. Please join me in giving the speakers a round of applause one more time. Only one quick word. I was really struck by something that, Sarah, you said, that this is a golden moment. That was actually a very interesting phrase. And when I hear all of you talk about the opportunities for creating healthier cities, I was filled with hope. And then, of course, you all pointed out problems, and I was filled with despair. But I think that's actually what makes this moment so interesting. I do think that I've been in the academic world in this space for about 20 years, and the past 5 years have been an acceleration of interest and opportunity in this area. So it's terrific to hear you all catalyze that. So thank you very much. Thank you all for joining us. There's a reception outside where the speakers will hang around for informal questions. Thank you for being here today.